you mentioned with ruxolitinib, obviously, that anemia or cytopenia is on target. You briefly mentioned some of the things we do in clinic using ESAs, sometimes thalidomide, danazole. Any investigational agents as promising, adjunctive therapy to ruxolitinib to alleviate anemia? I think you've led some of the original studies with the sotatercept, so maybe you can tell us about use of TGF-beta inhibitors in conjunction with JAK2 inhibitors. So,
Sure. So this is a very interesting area. This is a novel class of agents, sotatercept and luspatercept. These are activin receptor ligand traps. Basically, they are fusion proteins that bind up and sequester these ligands, which inhibit the terminal stages of erythropoiesis. So basically, by taking the ligands away, they don't let them bind to the activin receptor, and so that pathway is no longer active. So yes, we did an investigator-initiated trial with sotatercept, and we saw activity there, both with ruxolitinib and on its own. And I think with ruxolitinib is more relevant because of what you said, because ruxolitinib causes anemia, and it's important to counteract that. And then luspatercept was just approved for beta thalassemia. We had also heard at the 2018 ASH meeting about the medalist trial, which was positive in lower risk MDS. So there is a trial in myelofibrosis, again looking at it alone or in patients, as well as, I should say, in patients on ruxolitinib, both transfusion dependent and independent. The first results were at ASH 2019, and there too we are seeing activity. Now, this was not a registration trial, so it remains to be seen what the path forward is in myelofibrosis, but definitely a very exciting drug.
absolutely, thank you. So, moving from anemia, let's go to polycythemia. So, obviously, polycythemia vera is another common myeloproliferative disease that we deal with. Can you briefly highlight your approach of risk stratification for patients and evolving new data on other variables that are important in terms of prognosis for P vera? And then we'll talk a little bit more about treatment.
Sure. So PV, I mean, this is one of the things that really hasn't changed in a long time. I mean, when we were in training, this is the same that we learned about risk stratification, at least officially, which is that a low risk patient is somebody who's younger than 60 and has never had a thrombotic event, and a high risk patient is 60 or older, or has had a thrombotic event. So that is still the same. That has not really changed, although there is increasing recognition that leukocytosis plays into the thrombotic risk, not the platelet count, but the white count. There's a lot of evidence, a lot of mounting evidence for this, so perhaps it will get into the formal risk stratification. It hasn't yet, but it is definitely something that I pay attention to in the clinic. And if I see, for example, progressive leukocytosis, I'm going to try to change treatment to control that. So frontline for me, as for most people, is hydroxyurea. There was a study comparing hydroxyurea head-to-head against pegylated interferon, and there was no difference. The follow-up was short, but at least at that follow-up, there was no difference. So again, I think clinicians are fine using either one. It's probably a matter of preference. I think interferon can have some difficult side effects which can lead to discontinuation, but certainly an effective drug and one that can cause molecular remissions as
Absolutely.
well. So, and then we run into the hydroxyurea failure situation. There is a definition around this, but I think while that's useful as a framework, I think people tend to use their own clinical judgment for deciding when a patient is either resistant to hydroxyurea or intolerant to hydroxyurea. Intolerance is intuitively easier to understand, but resistance, again, if your counts are not being controlled, the spleen is not being controlled, symptoms are not being controlled, there are certain definitions for these things, but that would be an indication to change. And ruxolitinib is approved as a second-line agent. It's usually what I do. Interferon can also be used, but given the response trial, which was a trial in these very patients who are hydroxyurea resistant or intolerant, ruxolitinib beat best available therapy for a number of different endpoints like hematocrit control, spleen volume reduction, symptom reduction, complete hematologic response rate. So all of those things were superior for ruxolitinib. So that's what I tend to use in that setting, in the hydroxyurea failure setting.
Absolutely. Anything peculiar about use of ruxolitinib in P. vera compared to myelofibrosis? I think dosing is different a little bit. Side effect profile?
Dosing is different. So 10 milligram BID is where we start, and whereas in MF, we start based on the platelet count, unless they are very anemic, like we discussed. Side effect profile, as I alluded to earlier, my perception is that the shingles reactivation is more in the PV patients, and I think that's what the response trial reported as well. If
Right.
you compare that with the comfort trials, so again, anyone on ruxolitinib in my practice gets vaccinated against shingles.
Fine. Yeah, I think my practice is very similar to what you alluded as well. So obviously, if patients need cytoreductive therapy by virtue of being above age of 60, because the risk of arterial events increase, or if they've had event, if they are high risk, then I would, add cytoreductive therapy in addition to phlebotomies and baby aspirin for those patients. I do also keep eye on the leukocytosis. Sometimes it's one other variable that will make you decide on initiating therapy for patients. Hydrea is still the most probably common standard in younger patients or those patients that are motivated to achieve a low percentage of molecular remissions. I will discuss with them data with pegylated interferon. I think we will hear the updates on the raw peg interferon that's approved in Europe, not in the United States yet, but interesting data about molecular remission. But I think patients have to be motivated about the treatment because, as you mentioned, also the toxicity profile with interferon is more. Second line, I moved to ruxolitinib in those patients. Um, so I think we have similar pattern of practice there.
Yes, Ropeg is interesting. It is approved in Europe, as you said. It's given once every 2 weeks,
Right.
which is an advantage. And it was a frontline trial versus hydroxyurea, where they were initially non-inferior, but later superior, because interferon takes longer to achieve this endpoints.
Right. So I think all over it's really exciting time. I think we have two JAK2 inhibitors approved now, potentially two others, ropeg interferon approved in Europe. I think our understanding for those diseases had evolved dramatically over the last few years with the next gen sequencing
Mhm.
and the molecular data. Uh, any final remarks or comments you'd like to add?
I think, finally, after a very long time, this space is really exploding with drug development initiatives. I mean, JAK2 was discovered in 2005 and CALR in 2013. And obviously, it was the JAK2 mutation discovery that led to ruxolitinib and the JAK inhibitors that followed. But it's great to see so many different mechanisms of action being exploited. I'm sure there are many that we didn't touch on today, but it's great to see this happening in our field now.
Thank you. Thank you, Dr. Bose, for this insightful discussion. And thank you to our audience for watching this targeted oncology presentation on JAK inhibition and myelofibrosis and beyond.